Welcome to the third and final day of the conference. We have had an opportunity to learn from experts in our field over the last 3 days, develop new friendships, and strengthen old ones. For today's session titled Clinical Conundrums, we're first going to hear from our two speakers, then have our oral abstract presentations and awards. We'll then take a break to view posters, and then we'll have a debate on ovarian tissue cryopreservation, ethical dilemmas in fertility preservation, and then break for lunch before our afternoon session. I am going to introduce our first speaker for the morning. Dr. Dana Kimelman is an obstetrician gynecologist from Montevideo, Uruguay. She received her master's in reproductive science and medicine at Northwestern University, and her practice focuses on fertility preservation and restoration for patients with complex medical conditions. To this end, she founded and directed the Oncofertility Consortium in Uruguay. Besides her clinical practice, Dr. Kimelman is also the co-principal investigator of the ovarian tissue vitrification for fertility preservation, which is funded by the National Agency of Investigation and Innovation in Uruguay. Dr. Kimelman is currently working on a new project whose objective is to evaluate the oncofertility knowledge of REI physicians from Latin America. The title of her presentation this morning is Fertility Preservation in the Context of Low Resource Settings. Please join me in welcoming Dr. Kimelman.
Good morning. Thank you so much for having me here. I'm truly excited, and I'm honored to have all these rock stars in front of me. I hope you enjoy this presentation. I'm going to share with you the way we are working very far from here. So this will be the agenda for today. We're going to talk a little bit about the cancer situation in Latin America. Then I'm going to try to explain to you what it means to live in a low-income or high-income country. It's quite difficult to explain. How we are developing oncofertility in Latin America, the actual situation and the situation we plan to do, and the situation in Uruguay, which is my country. So this is Latin America, and all these countries are involved in this region. I'm going to try to explain to you the way we work in my country, which is quite different as the way you work here in the United States and also in Europe. So we have beautiful places. I really would like that after this talk, you all would like to come and visit us. There you can see pictures from Peru, Brazil, Uruguay, and we are very different. You know, sometimes we can say, okay, South America, everyone is like the same, but we speak different languages, we have different religions, we have different cultures, very different cultures. We have different income. We live in very, very different countries, and we have different governments, and we are authorized to do different things. So please raise your hands, the ones who know where Uruguay is in the map. Really? All of you know? Okay, it's this tiny country here. We are between Argentina and Brazil, which are huge countries, and this is a tiny country with 3.5 million persons living in it. So this is the cancer situation around South America, around 2,033,000 diagnoses in 2020. Breast cancer is, of course, as everywhere else, the main cancer diagnosis, and also testicular cancer for men. And you can see here the differences that the World Global Cancer Reports make between high-income countries and low-income countries in Latin America. You can see that low-income countries have a high incidence of cervical cancer, which is something that you usually won't see in United States or Europe. We have a high incidence of this. But of course, like we know in high-income countries, cancer incidence is higher. Then I wanted to share with you how are the regulations of IRT in Latin America. As well as I told you before, we have very different regulations. You can see here that Argentina has a law, Uruguay has a law since 2013, Colombia also has a law that regulates reproductive assisted technology, but many other countries does not. So I'm going to explain you how is the law in my country, that it started in 2013. It covers IUI, IVF, and ICSI for infertile heterosexual couples. So we have a limitation here. It does cover fertility treatments for cis lesbian couples, not for transgender, for cis women without a couple. And it did not cover fertility preservation for cancer reasons. And I'm going to tell you in a couple of minutes what's happening now. The coverage is partial. This means that patients pay what they can. It depends on the income they have. If they earn a lot of money with their jobs, they will pay a part of it. And if they don't earn a lot of money, they will pay a little bit. So we have like this big agency, which is public, which is called Fondo Nacional de Recursos, and we pay with our taxes for it, so they pay for treatments that are expensive in my country. So, regarding oncofertility, we know that we come from everywhere and we try to develop the field in our countries, but again, it is different in Latin America. So there are different options for fertility preservation. There are different regulations for third-party reproduction. The financial coverage is, it's not everywhere. We have a lot of religious restrictions in different countries, not in mine, but there are religious restrictions. There are cultural restrictions as well, and ethical attitudes, and a lot of people judging what others do. So Noli Osigmek and Dr. Salama published this interesting paper this year in Frontiers, where they did an interesting study regarding oncofertility registries around the globe. So what they wanted to show is the importance of registering what's going on. I mean, if we want to make progress and if we want to show what we are doing and help people to improve in oncofertility, we need to register what we are doing. So as you can see here, for Latin American countries, the 4 countries that were included, all of them have registries for cancer treatments and for fertility treatments, but not for oncofertility. So we need to start registering our work. Again, Dr. Salama published another paper talking about oncofertility options in different resources countries, and we can see here that in low-resource countries, there are less access to fertility treatments. And he also made this interesting list talking about the things that are needed in order to develop a good oncofertility program. So we need to overcome a lot of barriers, and that's necessary to make progress again. And a phrase that it's from this paper again, for me it's very important to make you understand what I'm going to explain you now, is that within developed countries there are maybe specific regions that may qualify as limited resources, because the money is not always destined to the same purposes. So we can live in a country with a lot of money, and even like that we don't have money to develop this field. So a little bit about Uruguay. This is a small country, I already told you, and the incidence we have for cancer patients under 40 years old is around 6%, which is, I think, the same, more or less, like here. So I have a confession to make, because I was invited to talk about low-resource settings, and when I went to see how is my country regarding income, I found this. So I'm not a liar. I'm going to explain you why, regarding oncofertility, we used to be a low-resource setting. So because high income does not mean high resources, because most of the money of the country where I live is not destined to science, to research, or to medical practices. So to convince you, I will show you that this is the last report of the Cancer Institute in my country. The cervical cancer, which is a historically marker of poverty, is the third cancer in women in my country. So we still have a lot of things to do. And as you can see, as here, incidence is much bigger than mortality. So we have a lot of survivors we have to think about, just like you. So when we started thinking, okay, how we're gonna work in oncofertility in this country, we started with a diagnosis of situation. So we made a survey of knowledge, attitude, and practice regarding oncofertility among healthcare professionals that take care of young cancer patients. And we found this. I mean, almost all of them understand that there are gonadotoxic effects. Many physicians know if fertility preservations may be offered to cancer patients, but 50% that said they know, but 49% said yes. And then a lot of physicians consider that oncofertility should be considered part of cancer treatment, but when we ask again if the concern about reproductive effects of cancer treatments in young patients usually are present in the clinical practice, we found that many of them said no. So this was not a surprise. I mean, it's the same that has been published in the United States and Europe, but we realized we have a lot of work to do. So when we asked if they usually refer patients to oncofertility specialists when a cancer is diagnosed, we found that more than 50% said or sometimes or never. So again, a lot of work to do. So we find out that we had two big barriers: lack of knowledge from physicians and personal health, and lack of money to be able to pay for these fertility treatments. And we realized that both barriers were linked. If we could be able to stop with the financial barrier, we would have more referrals. Because many physicians said, I'm not going to refer a patient if they will have to pay $10,000 to freeze their eggs. So that would be uncomfortable for them. It's not comfortable for me, so I won't do it. So one day I received a 36-year-old breast cancer patient who wanted to do egg freezing, but she didn't have money. So I talked with her oncologist, and we said, okay, we believe that fertility preservation should be part of her cancer treatment. So I want to talk to a group of lawyers that work in the university of my country, and we said, let's sue the government of our country and make them pay for her cancer treatment. And we went to the court. We gave all our explanations regarding why we thought it was important for them to cover this, and we won. And we won 12 times. So, thank you. So after this, if you can see here, this is from one single center. I'm going to explain you how it works in my country, but clearly the financial barrier was like the most important barrier, because we started to do a lot of more cases of medical egg freezing after this. So then it came the law. After this, they said, okay, I don't want to go to court anymore, so we're going to have a law. And we have a law, which is pretty nice. I mean, they give full financial coverage for gamete preservation, not embryos, oocytes, or sperm, for 3 cycles, so patients can do it again without paying anything, until 39 years old. This is a little bit controversial for men. We have no financial support for non-oncological reasons, and again, we don't have support for embryo cryopreservation. So we wanted to move forward. And we know that education is powerful, and we need to use, if we want to use this new resource that we have, we need to teach people how to work. So we published a book that talks about like basic concepts of oncofertility. So everyone, when is studying medicine, they can learn from this book, which was published through the university. Then the oncology department of the university every year updates their clinical protocols of treatments. And last year, for the first time, they included a chapter regarding fertility preservation for cancer patients, which was pretty nice. But what happens with referrals? Yesterday, someone was talking about like how to get better with referrals, and I want to show you how it works. That makes it in my country very hard. We have a very strange system health. We have a part that's public, which is for the people that has less resources. We have a private part, and we have insurances, which is for the people that really have a lot of money. And we have 3 ART centers, which are 3 of them are in the capital city, and the 3 of them are private. So the reason why I don't have affiliations in my slides is because I work in 8 different places, and I do counseling of cancer patients in 8 different places, public, private, and insurances. So that's not being a developed country regarding to health assistance. So since the financial coverage, we have done this number of cases between September 2022 and June 2023, which is a lot for the population we have. 45 cases were approved for oocyte cryopreservation and 34 for sperm, and the most frequent reasons are breast cancer and testicular cancer and hematological conditions. So how are we planning to expand? Okay, we want to know what are the mechanisms necessary to build a country-based medical problem, and we are going to use our country as an example because we think we've done a lot. So we need to know what we need to for every Latin American country to success. So we realized that we need oncofertility formal education in Latin America, which is, okay, what is the real formal education REI providers have, so, because it's not just freezing eggs or freezing sperm. So we will try to build a new medical field in Latin American countries, and we need evidence-based research to educate practitioners. So the idea is to make a survey where REIs will answer if they feel that they have formal education or they are really trained to assist this population, and then try to understand the ways in which continent-based, like Latin American and global-based, like with the Oncofertility Consortium programs, can be country-based programs supported by these great institutions. So we're going to do this survey. We're going to send it to 198 centers affiliated to the Latin American Assisted Reproductive Network. We will do an analysis of this survey, and then we will do a diagnosis of the situation. We will analyze the data, then we'll take an action, creating guidelines, books, education courses, and everything we can do to educate population in different countries, and then we will evaluate the results. So before ending, I would like to really say thank you to some people that was very nice to me many years ago. I don't know if Kristen is here, but Kristen Smith is a lovely person. She's the manager of the Fertility Preservation Program at Northwestern. I assisted my first conference in 2015. I was living in the US for lab reasons, working at Northwestern at a critical care laboratory, being a gynecologist, so I was not that happy. So I started to look for something to do, and I found that there was going to be an Oncofertility conference at Northwestern that month. I'm talking about 2015. I went by myself. I didn't know anyone. And someone told me, you have to talk to her. She was Kristen Smith. She opened her doors for me. She told me who should I talk to. She explained me how to work. And she's always there for me when I have to make a question or say something about a patient. She introduced me to these magical ladies. Both of them were my mentors in my master's, and I really want to say thank you to both of them, especially Teresa, which I think everyone misses her today, And yeah, I like to be grateful, and I think that we have to give opportunities to people, especially for people that are not from here. And I also want to say thank you to my co-workers. I wouldn't put 8 photos here, but I have like around 8 teams. And thank you all so much for being here.
Thank you, Dr. Kimelman. We have time for 2 questions. I have a question about your education curriculum. So is that a curriculum for medical schools? Can you describe that a little bit?
I mean, it's a little bit different here. You go to college and then you go to medical school. Mm-hmm. We go straight to medical school after high school. Yeah. We have 8 years and a half of medical school. And then we do our residency, gynecology residency, which is 3 years more. And we don't have fellowships for REI. So we have to travel and try to learn from other countries or stay there and wish that somebody will teach you something.
Yeah. And I ask because I know you have the survey for REI physicians and the knowledge amongst REI, but the barrier tends to be oncologists, right, in terms of referrals. And I just wonder how we're going to better educate the masses about how we should be caring for this patient population.
Yeah, that's a great question. I mean, in the country, we've been doing a lot of work, like going to oncologist meetings. Now we are like part of the team. What we decided to do at the beginning, this survey was presented to SWOG, and at the beginning they wanted us to do like a survey for oncologists, but it's impossible to reach oncologists from all Latin America. It's easier for REI because we have this network, and we decided to start, okay, what is that REIs need to know? I mean, this concept that everyone can do counseling for a cancer patient, I don't think it's like that, so we need to better train REI physicians, and then we will find a way to expand to oncologists. But it was like impossible for us to do a good work with a survey because we wouldn't be able to reach all oncologists in Latin America.
Thank you.
Thank you.